you for joining today's session. This is a crisis response training that's entitled Best Practice Strategies for Assessing Suicide and Homicide Risk with Youth and Adults. My name is Jennifer Hodson. I am with Health Management Associates, or HMA. HMA is a leading independent national research and consulting firm, and we focus on improving administration and delivery of public health, healthcare, and social services programs. HMA is supporting the Mississippi Department of Mental Health in its efforts to enhance the state's crisis response system by providing monthly online crisis response training. Before we begin this presentation, I want to acknowledge and validate all feelings and thoughts connected to experiences with this topic. Taking care of oneself before, during, and after a crisis response goes deeper than learning the technical aspects of doing this work. It's the recognition that we are our own instrument of care, and quality care has to begin with us. So just wanted to acknowledge all of that as we move throughout the presentation today. Right, I'm just going to get rid of a few things here so I can get through. So these are the learning objectives for today's training. I'm not going to read them all to you, but just know that we'll start off looking at evidence-based models that we are employing in this work, and we'll focus specifically on the ones that Mississippi has endorsed. We'll talk about warning signs, risk factors, and protective factors for working with individuals who are experiencing suicidal or homicidal ideations and at elevated levels of risk. We'll learn to differentiate a little bit between acute, chronic, and situational risk levels. And at the end, we're going to weave in how do we continue to promote being culturally responsive and trauma-informed in this work. So just to give you a little high-level view, we're going to keep the chat open throughout because we're going to have some interactive elements with the chat, but for Q&A, we'd love for you to be able to use that. And I have a couple of colleagues who are going to be monitoring that just in case something comes up that would be a great learning opportunity for everybody. So for the first objective, we're going to focus on evidence-based models. We're just going to focus on a few. There are a lot of other options out there. But these are some best practice strategies, and how do we walk people through suicide and homicide risk, particularly with youth and adult populations, because there are some slight differences. So in the chat box, what I would love for people to have the opportunity to do is to just share what first thought or feeling comes up for you when you think about individuals who are experiencing suicidal or homicidal crises. First thought, it could be a feeling, it can be a cognition. What comes up for you, if you can please put that in the chat for us. And I just want you to see where you and all your colleagues are at with this work. So sometimes we don't realize what a community we have around us and how we're feeling. Just going to give people a second to do that. Thank you. Martin put care, sadness, support, concerned. Thank you, Brent. Tasha, fear, hopelessness, tired. Right, right. Thank you. Thank you very much. Compassion, absolutely. Absolutely. Continue to put those in if you haven't had a chance to list yours yet. So there are a couple of evidence-based tools that we're going to cover, and I want to thank our Mississippi Department of Mental Health for providing us with the links below in red, as you'll see on the screen, because those are the bulletins that contain what the approved trainings are that are used throughout the state of Mississippi. So we're going to refer to them today in a high-level format, but just to reorient everybody to what we're using across the entire system. So with suicide and self-harm risk, there's a method called ASSIST. It's applied suicide intervention and skills training. And this is a collaborative safety planning system. There's lots of free tips. As you'll see, each is linked. So you have tip sheets. It is typically used for clinicians, although paraprofessionals might use elements of it and then refer to clinicians for some of the other components. There's another methodology called Safe Talk. This is for individuals age 15 and older. really steps through how to help people work through suicidal thoughts and connect them to the resources that can help and support them. And that is generally could be for non-clinicians. Um, so SAFE-T is suicide assessment. It's a 5-step evaluation and triage. So this is now getting into what a framework is that we can use to guide us through how do we identify levels of risk, the protective factors that we know are important to also assess for, giving a really thorough level of inquiry so that we know how to manage that level of risk. There's the Columbia Suicide Severity Rating Scale, which is another instrument, can be used by paraprofessionals and professionals. It's a 1 hour online video training. They have really good evidence with this. They have a tool that you can use, highly validated, and it's used to really assess the severity and immediacy of suicidal ideations across settings. There's also a version for adolescents. So there's a recognition that we need different types of language and questioning to be able to really do a really appropriate assessment across the populations. The next section of this slide talks about homicide and risk violence. This one is for youth specific, but the CDC has a youth violence risk and protective factors inventory that you can look at, and it's a framework that sort of helps identify risk and protective factors, again, free to the public. So I wanted to list that for you. And then for adults, the CDC also has one for adults with a similar name linked here. And there's also the structured professional judgment guidance for adult violence, and also that could be for self or other. So we're going to walk through several of these on the slide today, not all, but I wanted you to at least know where you can go for more information. When we're working with individuals who are experiencing suicide or homicide ideation, there's a general workflow that we'll go through. So the first and most important is to build trust and to join. So when we're working with people, we do want to be very concise and compassionate in our language, but we also want to meet them in their energy level of where they're at so we can join effectively and get a very good assessment. Then we're going to move into potentially like a safe talk model with the talk acronym, where we'll notice invitations that they might be having these thoughts that are impacting their decision making. They could be verbal, they could be nonverbal, and this can signal a person is thinking about self-harm. So noticing those types of cues, and we'll go into some of those more later, signs of distress. The A is for ask, asking clearly and directly, are you thinking about suicide? So a lot of individuals might be hesitant to use the language or will do leading questioning like, are you thinking about suicide? And shaking the head no. So we want to be very clear of our own nonverbals and verbals when we're doing these assessments. We want to listen very, very carefully to the person's story and really confirm the need for help. Not everybody who's having a suicidal ideation needs to go to the hospital or needs involuntary commitment. So knowing how to listen and then knowing how to develop that plan and hopefully collaboratively with that individual will give them the best outcome. And then keep safe, which is the K. So that is really connecting them to that next step. Someone who's trained to support them, like an assist trained helper or crisis service. So if the screen is positive, if we do go through that talk and we do find that the individual is experiencing ideations, then we'll want to use something like the CSSRS or the SAFE-T to do that deeper assessment. If there is imminent risk or a need for intensive intervention, then the assist can also help us with some additional safety planning. If it's extremely complex, high stakes, where we need a very deeper forensic history, we want to understand repeated attempts. We want to apply, what is called the structured professional um, judgment model, so SPJ. So it's a model, it's a framework for being able to do that multidisciplinary risk formation and assessment that we really need to do to make the best plan for that individual. So let's start with assist. So purpose of assist again is a structured interactive intervention for trained professionals to engage in this collaborative safety planning. There's a training, multi-day training that you would go to. The goal is to really explore those invitations or that ambivalence that people might be experiencing about wanting to live and not wanting to live. So how do we help explore that? Develop that collaborative safety plan, and then really confirming that that plan is something that the individual can commit to and that there's good follow-up afterwards to ensure that that plan is being supported by the systems that's supposed to support it. We want to focus in on really thorough collaborative interventioning, skill building, safety planning, and then that short-term follow-up is what the assist is designed for. And it can be used by trained professionals or paraprofessionals. Paraprofessionals typically will do parts of assist and then hand off to your trained clinicians. With assist, you're connecting and building rapport. Again, listening for lived experience, acknowledging cultural identity and trauma history. We're going to explore turning points, like what has helped you through hard times before. In some approaches, that's called exceptions or unique outcomes, things in the past that indicate this individual has some strategies and some factors, resiliency factors within them, protector factors within them. How can we tap into that so this hopeless place that they're feeling might become a little less? So looking for those moments or of hope, as we call it, that can serve as turning points to kind of help them see the value of developing a collaborative safety plan with you. And again, those safety plans are co-collaborating. So you work with the individual and anybody else who may be involved that they invite into that conversation in that moment to develop that. We want to reduce access to lethal means, and we want to identify coping strategies in those times. And then linking them to ongoing support. So that warm handoff is important, whether it's a verbal or for the phone, or if you're able, you're in an environment where you can walk them down the hallway or introduce them to that next level of care. Really important because once you've joined and built rapport, that individual trusts you, so that trust can then be borrowed and shared. So that's why those warm handoffs are so important. When we're using that safety, which is again that evaluating and triaging tool set, again, is to really help us to get a firm risk assessment in place. We want to identify that risk early and accurately. And that risk assessment will then help guide in decision making. The reason why these tools are so beneficial, and I remember when I was first learning to do crisis response work, it just helps to have a structure in place. Your anxiety is going to be elevated anyway. We don't want our brain, especially our prefrontal cortex, to go offline. And just knowing that we have these strategies in place helps keep our own brain as care providers engaged and keeps us from just going into that own place of fear, of not knowing how to handle it. So having these structured frameworks and being reminded of them is really, really important. You're going to focus again on those risk and protective factors, assessing that level of risk, and your audience can be pretty broad for using safety. So this can be from behavioral health crisis response workers, emergency department professionals, primary care, mental health professionals, and other people, crisis workers, school, community agencies who may encounter people who are experiencing a crisis like this. There's 5 steps for the safety that we want to identify for you. The first is going through those risk factors, and we'll unpack some of those a little later with a check sheet to make it easier. But this gives you some clinical information, some historical, and some situational factors. It allows you as the person working in that moment with that individual to be able to get an idea of where to go next. You're going to definitely assess for those protective factors internally and externally. So whether they're coping skills, resiliency factors that they've identified, or people around them, social support, other reasons for living, pets, children, religious or cultural values. So those are all protective factors we want to be able to understand and highlight. We want to definitely thoroughly conduct that inquiry about suicide, asking very direct questions about intent, plan, means, behaviors, and that's where the CSSRS or safety or other clinical interviewing techniques come in handy. We want to determine risk levels, so then again, we know we're delivering the appropriate next step care, and then document and follow up. So that last step is one that Mississippi does extraordinarily well and is working on, which is that follow up component. So it's not just responding in that moment, but it's how do we help tap into that to help that person continue to get ongoing support and care. A little bit about the CSSRS in a crisis situation. Again, it is a standardized tool that will help step you through. There's very structured questions. There's an adult and an adolescent version, and it really helps with that risk stratification and intervention process. There's really five core ideation questions that you'll find in this tool, and I thought it'd be helpful to at least include some examples of those questions. So, wish to be dead. Have you wished you were dead or wished you could go to sleep and not wake up? You know, so whether it's a very active or passive suicidal ideation experience, and some people will have that, they'll maybe not think of actively wanting to end their lives, but passively, if it happens, so be it. So both of those are concerning, but with different strategies and steps that we would want to pursue afterwards. Suicidal thoughts directly ask, have you had thoughts of killing yourself? Suicidal thoughts with method, have you thought about how you might kill yourself? Have you had these thoughts with some intent to act on them? So, is there a time, a day, a plan? If this next thing happens, then I'm going to do it. So, we want to see and understand just how developed that ideation and the plan is so that we know the urgency with which we need to respond. Once the brain has sort of walked down that path, it shuts down all other options for people. So they're not thinking about others, they're not thinking about all the other places they could go for help. So the more doors and windows that have shut for that individual, the more serious and severe it is. And then have you started to work out the details of how you might kill yourself or somebody else? So these components, these questions are very helpful for us in getting a firm understanding of risk. These are just some tips for using the CSSRS. You want to introduce it to the person you're with as a tool. I'm going to ask you some questions. It really helps me to know how to better serve you. It's not a test, it's just a way for me to make sure I am making with you the best plan of care. And I've given you some language on the slide of ways that you can language that after this training ends. We want to definitely prioritize immediacy. So if they've had ideations in the past 24 to 48 hours, we want to definitely be focusing on what's happening now or in the recent past. Because those are predictors, obviously, of acute risk. But if people have had experiences prior to that, and it feels in that moment like you can ask about those things and gather that historical information, that is also really important to determining level of risk. We ask these questions with sincere compassion, not judgmental. We want to watch our own nonverbals. We want to avoid euphemisms. So instead of you're not thinking of doing something silly, are you? We want to say things like, have you had thoughts about killing yourself? We want to normalize honesty. A lot of people in crisis have thoughts like this, and it's okay to be open. We want to assess for both ideation and behavior. So when you've had those thoughts, how strong were they? Were you able to push them away? For behavioral items, we want to ask about preparations they may have made, any aborted attempts, like they almost did it a few days ago, but they didn't. We want to really clarify what's happened. We want to look for those red flags, again, those preparatory behaviors, writing notes, obtaining means, rehearsing what we sometimes will see individuals do, and knowing that those elevate level of risk and severity. And then also asking about recent stressors losses, separations, that have really elevated a person to this space where they have exceeded their coping skills. We want to again listen for those protective factors, and then if there's any collateral information we can obtain from other people that are there, family members, friends, co-workers, EMS professionals, police, school staff. Sometimes what happens is they'll tell people what they're thinking, feeling, and believing, and then by the time you get there, it may change because they get afraid of what the next step is going to be. So those collateral supports will say, well, right now they're saying there's no issue, but just 5 minutes ago, this is what they said. And it's really important that we hear that because it's common that people might walk back from some of that for fear of what the next step is. And some people may have had bad experiences with the next step, and that's another part. So in the chat box, what I'd like for you to now is just share again that first thought or feeling that pops into your head when you reflect on an experience where you have provided crisis care to somebody who is experiencing a suicidal homicidal crisis. What did you feel or experience? What was that first thought or feeling? Okay, empathy, relief. Very interesting. Right. And that can be impacted in a variety of ways. Concern, compassion, tired. Yeah. Oh, we're going to go into some of this. Excellent job, everybody. Thank you for tapping into this. Okay, with the structured professional judgment, as we mentioned earlier, that's going to help us come up with that plan. It could be used for adult self or other directed harm. And it's a method for just combining evidence-based risk factors with professional clinical judgment. We're going to focus on that risk planning using some checklists, structured tools. Paraprofessionals can definitely use this. So it's not just for licensed clinicians, but typically those clinicians, behavioral health providers are the final judgment in that risk planning. So there are some key principles that I just wanted to lay out. We're not going to get a lot into theory for time's sake, but these are some of the values that you're going to see with this SPJ framework. Really focusing on those dynamic contextual factors, risk management, transparency, and accountability. So just so you have a little bit of the background on the method. This table, it really just is designed to separate out when we look at the components of SPJ. For adults, how might it look a little different juxtaposed with youth? So with adults, informants might be primarily self-report, medical records, collateral from family if available, whereas from youth, chances are it's going to be multi-informant. So you're going to have parents, guardians, teachers, school counselors, community providers. If you're mobile crisis response, you're going to an environment where chances are, not always, but that somebody called on behalf of the youth or in their best interest. So you're going to have collateral providers there. And it's important to get information from them. You're going to want to look at those contextual factors, environmental stressors, employment, and social relationships. Right now in the world, we have a lot of contextual factors that are elevating people's discomfort and dis-ease. So we want to make sure we're understanding what those are for different populations. For youth, a lot of it is understanding family, peers, school, extracurricular, neighborhood safety, social media exposure. Again, looking at protective factors for each group, assessing, focus, and then reassessing frequency. When we're looking at SPJ to assess and develop a risk management plan, you can apply these principles for both homicide or violence risk. There are free risk factors from the CDC or SAMHSA, and I've listed those in a table below, looking at historical events, clinical indicators, and then contextual factors. These are just checklists that I thought could potentially be helpful, and I'm not going to read through each of them, but for examples of informant content that you could get or sources of information. And if you were to develop something like this for your field worker, this could be like a checklist format, or there are other ideas, because in the moment when we're also elevated in our job role, have we thought about all these other ways that we could get other sources of collateral information to help us make a good decision on behalf of this individual and with the individual? So informants, as we talked about, individuals who may, or records, who may have information to help give context. These are examples of historical risk factors, acknowledging trauma, prior psychiatric or substance use disorders, previous self-harm behaviors. Now, not all self-harm means that the person wants to end their life, but it could be a risk factor. So we want to understand if self-harm's been a part of their experience in the past so we can make sure we're directing them to the right supports. We want to look at other clinical current risk factors, any current thoughts or intents they're having about suicide or violence, any severe depression, PTSD, mental health symptoms, impulsivity, poor judgment, substance use, experiences with psychosis, agitation. So are you hearing things that other people don't hear? Are you seeing things that other people don't see? Sometimes it's those things that are giving messages or telling people to hurt themselves or others. And it's really important that we understand if psychosis is a part of this person's experience. Contextual factors, access to weapons, stressors that are present, community violence or trauma, thinking about what a lot of our populations might be going through now with threats of ICE or arrest. So we just want to understand what the current exposures are because each community group, rural, urban, different environments or areas where all of you work, that might be slightly different. The protective factors are really important. It can be a little difficult to get at the very beginning when people are elevated, but as you're building trust and you can feel that they're maybe just coming down a few degrees, you can start to ask about some of these experiences. If you ask about protective factors too soon in the interaction, people might think you're overlooking their issues or pain. So we want to balance that real good connection you want to form with the individual and then making sure we're getting some of these things that'll help us to know how to make the best decision from that interaction. And this is just a summary checklist. Did we, come up with risk and protective factors? Do we understand what the triggers or warning signs are? Some people don't like to use two words triggers. You might say activators. Overall, your assessment of risk. Now, this low, moderate, high should be tethered to resources in a decision tree. So this isn't just an end all be all document. You can flesh this out depending on what your area of the crisis response team is. But overall, there's a decision that's made and then the rationale that's made. This is a little bit of a checklist for a crisis plan. So did you complete a safety plan? Was lethal means restricted? Was it discussed? Was it implemented? Did you involve family or other supports? Did you link to outpatient or case management? Is there a referral to inpatient or respite care that was made? Were there emergency interventions that needed to happen? Were there any warm handoffs or next steps that were implemented? And then the sign and date. And this just really is about making sure all the domains are reviewed. Because when we're in those moments and we're working under high stress situations, we want to have a checklist or something so we don't forget anything important. So just in sum, so with the first point of contact, it's often going to be family, peers, community members, law enforcement, 988 call takers, and you might use the safe talk as your first line, recognizing those warning signs, understanding and asking about suicide or homicide even, and then persuading the person to accept help and connecting them to crisis services. Once that crisis line or mobile crisis team, that frontline response is activated, they might use things like assist, where they're going to engage with that person in crisis, build rapport, explore that ambivalence, look at those invitations, and co-create that safety plan. And their role is really to stabilize the immediate crisis, imminent risk, and determine if that higher level of care is needed. And then the next is that clinical evaluation point. So once we get the individual, if needed, to the ER, crisis stabilization unit, or a behavioral health urgent care, that's when you're going to get licensed professionals who will really complete things, maybe like the CSSRS if it hasn't been done yet, or even again in a more formal way. And this is one thing to let the individual know is you might hear these questions several times. Please know that things are just happening so quickly that we want to make sure nobody is missing a part of your important story. So bear with us because some of that, this might be repetitive. Safety is again another one that you can use for triaging suicide risk. And then ongoing management and follow-up. So once, that acute risk phase has concluded and we're looking more at post-acute care follow-up, then your outpatient, your ACT teams, your integrated care teams will continue to use that SPJ to build that care plan out, looking at sort of a long-term risk reduction and management strategy. So as you can see, it's like a chain. It's like links in a chain that move. If it does and it's working well, they move along until we have stabilization. And we know that when that happens, we reduce the risk of recidivism or people cycling back through that crisis response network in order to get that acute need met because they're getting new tools and care along the way if this is done well. All right, we're going to do some polls really quickly. My colleague is going to put these up just to get a pulse check of where we're all at. So the first question we want you to respond to is how confident do you feel using the structured professional judgment in a real-time crisis? So I just surveyed it today. Some of you may have already known what it is and use it. How confident are you in using it? The next question is, when assessing suicide or homicide risk, what do you find the most challenging in the field? Is it gathering reliable information? Is it weighing risk and protective factors? Is it applying judgment under time pressure? Is it documenting clearly and defensibly? Is it building an immediate response or safety plan? No wrong answers, just want to see where you're at. And this will help the state to know where maybe there's additional trainings that can be provided. Just as a real world scenario, again, just want to see where you're at. If you're called to assess a 15-year-old in crisis who denies suicidal intent, but the caregiver reports recent self-harm and violent threats at home, what's your first step? Is it prioritizing the youth self-report? Is it prioritizing caregiver collateral information? Is it weighing both equally and proceeding with the SPJ checklist? Is it deferring to the long-term care provider to follow up? Talk to your therapist about that when you see them next. Question 4, in your practice or in your field work, what informant source do you find most valuable and when you're conducting that risk assessment? Is it the client's self-report? Is it family or caregiver input if they're there? Collateral professionals, clinical records or history, or environmental observations in your specific work? And then the last is, what is the biggest barrier you face when you apply SPJ? Is it lack of training, lack of time, limited access to records or informants, fear of liability or legal issues, or uncertainty about next steps after risk judgment? And I'm just going to have Rachel briefly put them up when she gets the results, and I'm going to move on for time's sake. So our second objective I want to cover today is on those structured approaches to look at warning signs, risk factors, and protective factors. So warning signs are oftentimes immediate and observable. Risk factors are more long-standing or underlying vulnerabilities, and that would increase likelihood of risk. And then the protective factors are the things that buffer it. I put together a slide for just youth because I wanted you to have access to some of the things you might see and understand or hear when youth are going through these different elevated risk states. So some of the short-term warning signs and longer-term and then protective factors that you can ask about. So an example of a short term is they're talking or writing about death. So some teachers might pick it up in their artwork and their short essays or in a withdrawal of work. So these are all things that might show short-term risk. They might engage in threatening behaviors. Long-term risks is if we know this person has a history of trauma or abuse or a history of conduct disorder or aggression and a lot of exposure. That doesn't automatically mean this individual will develop suicide or homicide ideations, but they're at elevated risk. We want to make sure they have support. And then those protective factors we talked about earlier. This is just a vignette that I put up here, and it has a poll to go with it too. So if you have a 15-year-old male that's brought into the crisis center by his aunt, he posted on social media, "I don't want to be here anymore." He denies suicidal intent, but reports feeling overwhelmed after bullying at school. His aunt shares he's been cutting his forearms for the past month. He appears withdrawn, avoids eye contact, and shrugs when asked about supports. For the first poll is, what would you identify as the primary risk type for this individual? In the next poll, we want you to just type in the text box some risk factors that you think represent elevated concern. And in the last poll, what would you say is the immediate intervention priority? So, would you hospitalize immediately? Would you develop that collaborative safety plan with the aunt and the youth to restrict means and schedule close follow-up? Would you refer to outpatient therapy and monitor in a month? Would you call the school principal to address bullying directly? So what are some of the things that you would see as your immediate intervention priority? Okay, and as you're finishing up your responses to this, we're going to just move to the adult. Again, the adult protective factors might have slightly different components to them, the way that they're expressing short-term warning, long-term risk, some overlap with youth and some different. Having lived longer, they might have had opportunities to experience, unfortunately, more painful, difficult events. And so wanting to understand that with elevated risk, and then those protective factors that could help, provide some safety and support for them. Right. And for time's sake, we're going to move past this particular vignette, but I want you to know that it is in the PowerPoint deck for you, and it asks a lot of the similar types of questions. So it just kind of allows us to sort of get a sense of what, an individual in the situation might think or do. And you can do this with your teams in your work environments, just to kind of level set, where are we at with these types of presentations and what would we do? I find vignettes are a nice way to just create some space and distance, but yet have some really good discussions. Okay. The third objective I want to go through today is just to differentiate between acute, chronic, and situational risk. We've talked a little bit about that. But acute risk obviously is immediate short-term risk of harm to self or others. These can be suicidal thoughts with the plan, intent, or recent attempt, access to lethal means. We see escalating agitation, potentially intoxication or impairment of judgment. The response is immediate, so we need to make sure there's immediate safety, removing means, staying with that individual, involving emergency services if needed. Sometimes we're able to transport safely ourselves if it's a loved one. Sometimes we don't. And I am always the type of person that's like, if you even have a hesitation, then we want to make sure we get them safely transported. And then the time frame, could be hours to days. It just really depends on the level of risk. Chronic risk, again, is ongoing. History of suicide attempts, self-injury or violence, persistent mental health or substance use disorders. They have a lot of enduring, oftentimes social and environmental stressors like poverty and trauma. They may appear stable at the present, but at baseline, there's always that elevated risk. And you may have worked with people where they say it's always a thought there. I'm just able to like push it down. Um, and then the long-term treatment and monitoring, and this can be a weeks to years sort of approach depending on what a person's baseline risk is. It's hard to imagine always living with a sense of those ideations present. Lots of people do. And then those situation specific stressors or life events that could catapult somebody into just not having coping skills or supports or an environment where they can effectively get their brain back online and think about ways to work through it, like a significant relationship or job loss or loss of housing or loss of a loved one who is suddenly taken from them. Academic failure for a child who has never experienced that before. We see a lot of this, for example, in med school students who get to a point in their education where their capacity is less than what the demand is. And so new sets of skills are needed. This can happen as children age through educational system or as employees move up the ranks in responsibility. All right. And this is usually days to weeks that we'll see that. And it can resolve when the stressor lessens unless life just happens to do the Murphy's Law thing and you have one situational stressor after another. These are just examples of risk levels and types of interventions that you can do at each of those levels of risk. Some, all involve a safety plan in place. So regardless of where a person is at in risk, we always want a safety plan. It just depends on the urgency of those responses and those resources, depending on the level of risk. I'm a big proponent of make sure they have somebody to talk to after you part with them. So there's always going to be that warm handoff present because we never know when they're going to escalate again. The vignettes that we had earlier, I'm curious to know with the polls, if you want to, let me see if I can share the results here. Oh, okay. I'm going to stop sharing this. Okay. We'll bring that in at the end if we're able to do that with time, but I want to make sure to get through this next little piece. Um, So the last objective, this is where I really, it was important to have that overlay, that framework of being culturally responsive and trauma informed in this work that we do. So it isn't one way fits all. We have to look at the environment that we're in, the individual level that we're working with, the context around them, and then the history or involvement they've had or haven't have had in crisis response previously. So not all people who've been involved or have been close to the source of their pain have been kind, have been effective. And so we're walking into an environment, we have somebody who's very dysregulated in their all of their trauma, is activated at the same time. And so how do we approach that with compassion and sensitivity? So some of the core principles that we'll use is being culturally responsive. So we want to recognize how people's culture shapes how they think about suicide, violence, help seeking. We want to avoid making assumptions that just because we are a member of a group or population, that everybody in that group or population thinks or feels the same way. So we want to learn it from their perspective. Using interpreters or cultural brokers can be extraordinarily helpful to bridging when we won't have a sense of the worldview or the language and the nuances that words that we might use may not have the same meaning or land the same way. So having those interpreters or cultural brokers there can be extremely beneficial. Again, being trauma informed, sort of assuming that trauma histories may be present. So we want to pretty, my default is to just walk with the same kindness with everybody using a trauma-informed approach, asking for permission, giving choices where we can, so that people feel they have some agency and control. Being very collaborative, so we'll work together to understand what's going on. I'd like to do this with you, really does help people to de-escalate a little bit because their understanding of crisis response is people are going to you know, whisk you away and tie you down and you're going to be treated like a number. I mean, there's a lot of stigma that comes with asking for help that we have to overcome as crisis response workers. So really looking at that shared language when addressing and discussing risk and safety, using their language as much as possible, focusing on those strengths and resilient factors, not just risk. Speaking in a safe, calm tone, um, giving pauses allows time for processing. Your brain's probably going a million miles an hour, like, a duck on water. You don't see the legs underneath the surface going like you just see very calm. So, watching your breathing regulation, as well as looking for elevations in the person that you're working with. We want to adapt phrasing to their language. That's being culturally responsive. We want to acknowledge and validate. Um, we want to connect to culturally meaningful supports, family, faith leaders. If they say, I'd really like my pastor to be on the phone as you talk with me, who all needs to be involved so that we can provide the best care possible and help this person to embrace the care that's being offered. We want to ensure safety and comfort, so making sure we're moving people to a place, maybe not a public place, but a private place where we can have a conversation. Um, so any kind of accessibility barriers we want to be able to be mindful of. Direct and compassionate questioning. So have you thought about ending your life? Have you had urges to hurt somebody else? It's also tone, like using that warm, compassionate tone, not just the clarity of your words, but the tone that you're using. We want to balance those informant sources, observe trauma cues, really contextualize risk, document with dignity. So making sure we're capturing those risk factors and representing them in a kind way. If the person were to read what we wrote, so to speak, would they be comfortable with what we wrote? Now, if you put things in quotes, that's one way to capture exact language if that is important to your assessment and your treatment. And then normalizing disclosure, reassuring the client they're not alone and that help is available. And this is assist, just some strategies for building that collaborative safety planning. So ways that we can be trauma informed and culturally responsive when we go through each of those stages of assist. So when you use that, how do I use it in a way that's trauma informed, culturally responsive? And we've broken it down and given you some examples for each of those stages. So for example, in developing a safety plan, we can be trauma informed by emphasizing client choice, avoiding coercion, and normalizing difficulty. We certainly, when we move into these opportunities to provide help, we want to meet people where they're at and not make it sound like what they're going through is not that big of a deal or not that difficult or easy to fix. And sometimes new professionals can come across that way because they're thinking so by the book that they forget to sort of bring it to the client or to the individual as the center. And if we make it sound too easy, they won't connect with us. So it's really important that that part is present. And then trauma informed is again avoiding coercion, um, and emphasizing their choice where we can. Okay. This is a little case vignette, and I'd like to bring in at the end because I think it kind of brings everything together. So, and these are things I'd love for you to put in the chat. if you could for me. So Andriy Kovalenko is a 55-year-old father who immigrated from the Ukraine 3 years ago. He's seeking a better life for he and his family. He recently lost his job as a construction supervisor, and he feels like he's failing his wife and his two teenage children. He has brief thoughts that life isn't worth living, but he has no plan. Andre has a history of trauma, including exposure to violence during political unrest and the war in Ukraine, as well as the stress of leaving his extended family behind. He primarily speaks Ukrainian and is hesitant to seek mental health support due to cultural stigma and a desire to appear strong for his family. Despite these stressors, he has a deep commitment to his family, resilience from surviving past adversities, and personal faith. He is currently feeling hopeless, isolated, and worried about the future. So if you could, and you can also, let us know if you want to come off of mute, but if in the chat at the very least, if you could put what are the risk factors that you identify already for Mr. Kovalenko? And I'm going to skip over here. Where did it go? Into our chat. There we go. So what are some risk factors that you identify for Mr. Kovalenko? The thought that he is failing at life and thought about right. Language, barriers, right? And he's saying that he's a failure at life. That is a big, so he's not saying I want to end my life, but we're listening for that. And that's what we would call what that verbal cue, that invitation to ask more. Finances, right? That is a risk factor. So if his identity is as a provider, the finances are a huge challenge. Great. All right, question two, what are the traumas that you pick up on that are identified in this vignette? What traumas has he survived already? Exposure to political violence, the war, yes. Okay. Immigration, absolutely, Patricia. But that process we have come to learn is not a smooth process. So could have experienced lots of time being separated from loved ones. Okay. Losing of a job can also be a trauma. What are cultural elements that are important when we work with Mr. Kovalenko? What would we want to make sure is present so that we could work with him well? Absolutely, you all are doing a great job with the other parts of the trauma. What are cultural elements? Translator, absolutely. So there are just some words, some languages that don't translate in English, even if he can speak English. So helping him to find somebody who can speak the language with him so we get the most accurate assessment possible. And then let's end with protective factors. What are some protective factors that you can see with Mr. Kovalenko already? What are some of the things that we want to take note of that maybe has us faith? Good. Worried, but worried a little less. Family, deep commitment to his family and faith, right? Wife and children, family. 100%. 100%. So when I hear those things as a provider, as you do as well, clearly, we know that, okay, these are things that give us a little time. Give us a little time. We take it very seriously, but we know that these things are giving us a little time. So in that greater assessment process, we can right size the next steps. Very good. These are it's a table of risk factor resources that I provided for you from the CDC, NIOSH, SAMHSA. So if you wanted to go into the presentation and sort of learn a little more about what are some risk factors that I need to be paying attention to, wanted to at least give you some really good resource material that you can use. All of us come from different experiences, so it's really important that we have resources that can help us in our roles. I want to show you a little bit about the trainings that are available. The mental health department has been doing an excellent job of posting these almost immediately after they're recorded, but please know there's lots of other topics that can complement what you already know and deepen what you already do know. So they're available on DMH's website, YouTube, so they're a great way to listen and direct colleagues to that information as well. And we also encourage you to follow us on social media, so Facebook, YouTube, Instagram. All of these are really important ways to stay up to date on additional trainings, resources, and supports that are available to you. And that ends today's training. I just want to thank you all for your time and attention. You've been incredible. Your participation has been great. And thank you again for all the incredible work that you're doing. We will let the chat stay open for just a few more seconds as we have a link to the YouTube channel in there that you can grab. Thank you, and I hope everybody has an amazing